Welcome to Diabetes Day by Day, the American Diabetes Association's official podcast. Since this month is American Diabetes Month, this episode will focus on the American Diabetes Association's theme this month, Today's Diabetes Hits Different. I'm Dr. Neil Skolnik, professor of family and community medicine in the Sidney Kimmel Medical College of Thomas Jefferson University, and joining me is my co-host.
I'm Dr. Sarah Wettergreen, an assistant professor in the Department of Clinical Pharmacy at the University of Colorado's Skaggs School of Pharmacy and Pharmaceutical Sciences. In this role, I also practice as an ambulatory care clinical pharmacist at the UC Health Lone Tree Primary Care Clinic.
Sarah, we want this podcast to be an important ongoing resource for people with diabetes, and to do so over time, we're going to cover big issues and details.
That's right, Neil. Today we are talking about the American Diabetes Association's theme for this month, Today's Diabetes Hits Different. In the last 10 years, there have been such incredible advances in diabetes care.
It really has been amazing, Sarah. I feel fortunate to live in an age where science has advanced care, and there's just so much we can do with diabetes. To our listeners, this is going to be a critically important episode. Listen carefully, even write down some hints and bring them in next time you have a diabetes visit, because we're going to cover changes in technology, changes in how we personalize the care of people with diabetes, not just to get better control of blood sugar, but also with the idea of decreasing complications. And that's a critically important aspect, as we'll talk about. Then at the end, we'll talk about some resources that are available through the ADA website. To start off, Sarah, do you want to go over some of the important new technologies now available for monitoring blood sugar levels?
Sure, Neil. Yeah, I had some fun looking into some of the history of where we've really come over time in terms of measuring glucose. Looking back historically, really, home glucose monitoring started in the 1960s to 1970s. And at that time, the primary method used to monitor glucose levels was pricking the finger and checking blood sugar levels through a blood sample. If you think about that, that is not terribly different than what we see for a lot of people today. So many people are
Mm-hmm.
still using similar technology to this. But we do have more modern technologies now and newer technologies that help make this process of monitoring glucose so much easier. Many people living with diabetes can now monitor their glucose levels without pricking their fingers by using something called a continuous glucose monitor, or CGM. So, looking back, CGM technology has existed for a little while. It started back in the early 2000s, but I feel like from my practice and probably yours as well, Neil, we've started to see this come to be much more common now in terms of availability and use. And with these devices, we see continuous improvements. They're more accurate, easier to use, and smaller.
Yeah, it's really interesting. They've kind of taken the diabetes world suddenly. And I say suddenly because it's really just a few years ago that for most people with diabetes, the best you could get to was sticking your finger, and it's uncomfortable. It's important, particularly if you're on insulin. If you're just on oral agents, it may not be as important. But certainly if you're on insulin, you need to know what your sugars are doing. But that's hard to do. CGM is this amazing device, and it was available for a while in really, kind of upper end devices for people on very difficult insulin regimens, but it's now entered into common use. I was in Walmart the other day, and I actually saw one of the CGM devices advertised in the pharmacy at Walmart. And I say it that way because it's common. They're easy to use. You just put it on your skin, and it has a little device that just pokes into the skin. It feels like a little skin prick when you first put it on, but then that's it. And then you're able to scan with your smartphone to see on a regular basis, as often as you're interested, what your sugars are doing. What I've been amazed at, because I don't know, Sarah, have you tried this yourself at all?
I have, yeah. I've tried a couple different versions of devices available, and it's always fascinating to learn all of these differences and like what based on what you eat, what the reaction is. You might exercise and see impact there. It's just fascinating.
Yeah, and I found my own curiosity, as I have seen occur with my patients, drive me to like scan this all the time. So I'd eat some carrots, see what happens. Then I'd eat a cookie and see what happens. And you begin to learn though that when you don't eat properly, wow, does that sugar go up? And it becomes more than theoretical. What we see with patients, and the evidence supports this. I know I've seen this. Anecdotally, I'd be interested in your experience. When people start using it, they start modifying their behavior on this based on this really quick feedback loop that allows them to see the consequences of their actions. And you exercise more, particularly after eating. You don't get that spike in blood sugar. If you eat something that you shouldn't, and then you see your sugar go up, you really stay away from that the next time in a way that the same thing doesn't happen if it's just theoretical. I'm curious your experience.
I feel the same. I feel like we all have those moments where, I have a big sweet tooth. So when I wore my glucose monitoring device using CGM, I would notice different sweets or candies that I would snack on and the reaction. And that would encourage me, okay, well, I think I should probably go for a walk, balance things out a little bit, bring these back down before I get to my next meal. And what's great is that these technologies continue to improve. So some of them you do have to scan to get the information, and from especially the newer devices or different types of devices, some of them you don't even have to scan anymore to be able for to have all your glucose data collected. So it's just making it easier and easier for users.
It really is. I've been amazed when you look at the literature on this. It really fits what you and I have experienced anecdotally, which is you can lower your hemoglobin A1C by about zero point 0.5 to zero point 0.7 or 0.8% without changing any medicines, which is really about what you get when you add some of the additional diabetes medicines to your regime. So, just by this natural change in behavior that is a consequence of understanding how your own body reacts, you see these improvements in blood sugar. And this is where I'd encourage our listeners to talk to whoever is taking care of their diabetes, because the truth is we don't always think to recommend it. It sometimes is and sometimes isn't covered by insurance. So that can be an issue. I think it helps for everyone. I think it becomes pretty important, particularly if you're on insulin.
I agree. Yeah. So typically for people who are on multiple insulin injections per day, insulin coverage is a little bit easier. You're more likely to get coverage. But I feel like we're seeing growth in insurance coverage for people who maybe are even only on oral medication. So I'm glad to see this opening up practice and availability to so many people.
Yeah, let's go ahead and people can be intimidated by new technology. This is one of those. There's no reason to be intimidated. There's so many great YouTube videos to go to learn how to use it, and it's actually easier than it would seem to be. So I'd encourage people to give that a try. Sarah, let's shift to treatment, which is another area when we talk about diabetes hits different. Wow, it wasn't that long ago, and I remember, the only medicines we had were insulin, sulfonylureas, and metformin, and these are still critically important medicines, but they're not the only medicines that are available to us now. And while they lower blood sugar, one of the exciting things about the new medications, and we'll talk about some of them, is the ability to lower blood sugars without an incredibly high risk of causing blood sugars to go too low or cause hypoglycemia, which is one of the scary things about sulfonylureas and about insulin that all of our listeners really do need to pay attention to. In addition to better results on not causing hypoglycemia, some of the medicines really do achieve what we've been trying to do for so long, which is have significant and important decreases in some of the complications of diabetes. And we'll talk about them perhaps as we go over each of the different classes. Sarah, do you want to start with one of the new classes?
Yes, absolutely. So, one thing that I just want to highlight for our listeners, if you are someone who has a type 1 diabetes diagnosis, these are not going to be for you. Insulin is your mainstay of therapy. That is the primary option. But for people with type 2 diabetes, we really do see an emergence of new treatment options. There are many different drug classes that we won't even be able to dive into today, but really, what we're focused on are a couple of newer types of medications. We'll talk a little bit about how they work and some of their additional benefits. And really, in each of these classes, we just continue to learn more and more about what they can do in terms of not only lowering blood glucose, but some additional benefits like cardiovascular risk reduction. So, the first I want to start with is the GLP-1 receptor agonist class. A little bit of a complicated name, but basically, what these medications do, they help to lower blood glucose through a few different mechanisms, but they also have another mechanism related to slowing gastric emptying, meaning it's slowing the process of food in through digestion. And this helps to decrease appetite. Through this, we can see benefits in helping people to decrease their caloric intake. They feel more full, they feel comfortable after smaller meals, and this helps to support a decrease in body weight if this is desired. Now, when I think about that, I often think about these types of medications and we'll think about side effects because all types of medications have side effects. But some of these side effects might be desirable, like weight loss, and some of them maybe not as desirable. So, through that same mechanism, while it can help with helping to decrease body weight if that's a goal, it can also relate to another undesired side effect of nausea. But that only happens in about 1 in 5 people who take that medication. So, again, not for everybody.
The important thing and the great thing now is that the same medicine is not for everyone, and if one medicine doesn't work, there are other medicines that will. Any other things we should be aware of with the GLP-1s?
Yes, that's exactly right. So thinking about the different characteristics of different people and different medications, it's really true that the same medication isn't for everyone. So certain people who have diabetes and other risk factors or other conditions, they might benefit more from use of a GLP-1 receptor agonist, the medications in this drug class, because some of these medications can help reduce the risk of events from heart disease like heart attacks or strokes, and can also have some benefits for the kidney. So it really is dependent on the person. And then another thing to think about with these medications is administration. So, being a pharmacist, I know so many people are against needles. They are not going to use anything with the needles. So, a majority of the medications in this class are either given as a daily or once weekly injection. But there is one in this class that's available as a pill. So, at that case, you don't even have to worry about the needle.
It's so important, and that's right. And the needle is not the old large syringes we used to think of. These are easy to use pen devices. Where in some of the devices you don't even see the needle there. So they're easy to use. It's an important option as you talked about. Let's go on to another class of medicine, which really have been pretty amazing. They're called the SGLT2 inhibitors, and they work through a mechanism that just a few years ago we didn't even know existed in diabetes, and that's the kidney. The amount of science, these incredible scientists and that look into diabetes really have led us to have the opportunity to use these amazing advances. So we've known since the days of Hippocrates that people with diabetes spill sugar into their urine. How did they know that in Greek times? Well, you talked about old ways of looking at blood sugar. Apparently, in Greek times, they would taste the urine, and if the urine tasted sweet, the doctor knew that the patient had diabetes. We left that behind long ago.
Yeah, please.
But but what's amazing, even having known that, we didn't think of the kidneys as a way that we could help regulate blood sugar. And they discovered a class of medicines that stops the kidney from resorbing sugar after it spills out. Makes sense then if you're spilling out more sugar and not resorbing it, you lower your blood sugar and you actually are getting rid of some calories that way too. So, this is another class of medicines that has some weight loss attached to it, not as much as the GLP ones that you just mentioned, but some weight loss rather than weight gain that we get with some of the other classes like the sulfonylureas. They're well tolerated. There's a list of very, very rare side effects that I'd encourage people to look up. I don't want to spend a lot of time on that, but where I want to spend the time is on the incredible promise that this class of medicines has in three particular areas. One, overlaps with the GLP 1s for people who are at high cardiovascular risk or who have established cardiovascular disease. This class of medicines, the SGLT2s, just like the GLP 1s, decrease the risk of having a heart attack. Pretty amazing advance. Another area of heart disease where the SGLT2s particularly stand out, and this is important for actually 1 out of 5 people with type 2 diabetes, is heart failure. This decreases the risk of needing a hospitalization due to buildup of water and heart failure. So, pretty amazing there. And they have an effect over a really short period of time, being helpful there. And then finally, a pretty amazing effect on slowing the decline of kidney function. Kidney disease is a big issue and a big threat for people with diabetes. And this class of medicines, and it turns out it was first studied in diabetes, but now even in people with chronic kidney disease called CKD without diabetes, it has a beneficial effect on the kidney, and it decreases the decline of kidney function that can lead to dialysis. So, really, a pretty diabetes hits different
Yeah,
now, right,
it
Sarah?
does.
And we have all of these opportunities for us to help our patients and for patients to help themselves by asking the correct questions to the people who take care of them.
And it's fascinating that, these medications were new. It's not like they were specifically, made for these other conditions like heart failure or kidney disease, but just through these even safety studies, they're just looking to see, are these safe in people who have heart disease? We're actually finding not only is it safe, but it's actually helpful. And so I think we'll continue to learn more and more about these different medications and newer agents. New drugs will still come to market, and we'll find these additional benefits that we didn't even know were possible. So it's really just exciting that we continue to see new promise and opportunities in the healthcare future.
Now, Sarah, as a pharmacist, probably it was easy in the old days. If someone had diabetes, here's the medicines they get, and everyone looks like they're on pretty much the same medicines. Is that still true, or has that changed?
We're really into personalized medicine now, and personalized medicine can mean a lot of things. Sometimes it refers more to like genetic testing. In this case, I really think of it being specific to the individual person. So if you and I, were in a room and there were 10 other people there and they were all living with type 2 diabetes, each of those 10 individuals would probably have a completely different medication regimen. Some patients might want certain medications or have seen certain commercials, but maybe some things work better for them than others. They might have different risk factors, they might have different needs. And so depending on each of those different experiences, everyone's approach to living with diabetes might be different too.
I think that's so important to realize because we all talk to one another, and here there really is that importance of personalizing care. Another change that we've seen in practice, and it's not coincidence, right, Sarah, that you and I are talking about diabetes. We're both experts in diabetes. You're a pharmacist, I'm a physician. It's not just doctors that are taking care of people with diabetes. It's doctors, it's nurse practitioners, it's physician assistants, it's pharmacists, and it's a whole team. For those of our listeners who were with us last episode, we talked about it takes a village. It's a whole team of people that care for individuals with diabetes.
Exactly right. And even how that team approaches care, I think, has really shifted over time. If you think historically, patients would go into the office and talk with their doctor, and they would wait for their doctor to tell them exactly what to do with their medication, what to take, how much they should exercise day to day, what specifically to do. And practice is different now. We do have all these different team members, but we're using an approach where we really want the individual, the person living with diabetes, to direct their care. They can make the decision of which medication is best for them based on information provided about pros and cons of different options. I really like to present a few different options when I take care of patients and say, these are a few that I think would be reasonable for you. Here's their pros and cons, and what do you think of all this? And let them decide, because it really is that person who's living day to day.
It's so important. Sarah, we only have a few minutes left on our podcast. Can you just touch on some of the resources that are available for people?
Absolutely. I feel like the ADA, or American Diabetes Association's website, is just a treasure chest of information. If you click around, there is just so much information there that can be really helpful. And you can dive a little bit deeper into some of the topics we started to touch on today. Things like continuous glucose monitoring technology, other technologies that we didn't even have time for today, and certainly more information about the medication options we discussed and other medications that are available. But of course, other resources for that information, we would definitely recommend working with your diabetes care team, which might include your doctor or your local pharmacist, about medications as well. One last resource I want to share, there's another resource called Know Diabetes by Heart. It's a specific program from the American Diabetes Association, and they have a whole web page. This allows a free program that's actually a 12-month program called Living with Type 2 Diabetes. In addition to that program, there are other resources on the website that you can access without joining the program, things like recipe ideas, articles, and a newsletter.
Sarah, it's so important. Today's diabetes really does hit different. And I love what you said, that one of the biggest ways in which it hits different is that the patient is in the center of care. The person with diabetes increasingly is empowered and should be empowered to have this knowledge through resources like the podcast we just did, through things like the American Diabetes Association's website, to know what is right for them, and to ask us as the people helping them with their care to get the best care possible. Sarah, it is always a pleasure talking about diabetes with you.
You too, Neil.
For the American Diabetes Association, I'm Dr. Neil Skolnik. Thanks for listening.